We will wait a little more because I think there are rooms with people there yet.
No problem.
Okay.
At the end, it will be some questions, and perhaps you will need, you will help me to understand very well all the questions.
Okay, you have the moderator, Antonio Pedrero. I think he will introduce you and help you.
We will try it, Xavier.
Thanks a lot. Where are you from?
I'm from Madrid.
Ah, okay.
Universidad Politécnica de Madrid.
Oh, perfecto. Ahora sí.
Before starting, thank you, Javier, for coming.
No problem. It's a pleasure.
We're anxious for your talk. I believe it will be very interesting, dealing with other aspects of acoustics, which you consider relevant to integrate it in the themes of the International Year of Sound 2020 and 2021. So thank you very much for coming.
You are welcome.
We are just waiting for room 2 to check if it's already finished.
Just to comment that this online meetings is very strange. When nothing happens on the screen, it seems that we are in a dead world.
Yes, but
It's strange. It's really strange. When we are in a room, it's completely different. We look at the others, we comment, we talk, and
of course.
Okay, room 2 has finished. So when you want, you can start. Okay.
I'm gonna shut up myself.
Okay, good morning, everyone. It's for me a big pleasure to introduce to you the speaker of the next plenary lecture entitled Diagnostic and Therapeutic Application of Ultrasound in Medicine. The speaker is Dr. Xavier Serres, and I will make a brief summary of the impressive curriculum of Dr. Serres. Xavier Serres Grisam was born in Barcelona in 1964. He is a radiologist specialized in interventional ultrasonography, mainly related to oncology. He earned his medical degree from the Universitat Autònoma de Barcelona in 1988, and completed his residency in radiodiagnosis in 1993. He earned his PhD in 1995 on the use of ultrasonography in the study of mediastinum. In 2003, he joined the Vall d'Hebron Hospital in Barcelona, and since then, his career has focused mainly on interventional procedures guided by ultrasonography. He also participates in teaching activities in the field of radiology and ultrasound interventions. In this sense, Dr. Serres has held different academic positions for more than 20 years. At present, he is associate professor at the radiodiagnosis teaching unit of the Hospital Universitari de la Vall d'Hebron. Moreover, he has led and takes part in research projects focused on the training in ultrasound-guided biopsy with a virtual simulator. Finally, he participates in the design and clinical essays of new biomedical devices, such as new mechanisms for biopsies and puncture aspiration. Thank you very much, Dr. Serres, and you can start your presentation.
Thank you very much, Antonio Pedrero, for this nice presentation. Dear everyone, first of all, I want to thank you, Jorge Patricio, for inviting me to share with all of you my professional experience in the diagnostic and therapeutic applications of ultrasound in medicine. For me, it's a pleasure to have engineers in my audience. In the field of diagnostic imaging, we have two energy sources that allows us to obtain images from our body without no incisions or interventions. We have electromagnetic waves and ultrasound waves. With electromagnetic waves, we can have X-ray, computed tomography, nuclear medicine, and magnetic resonance if we add a powerful magnetic field. And we will talk in this speech about ultrasound energy. In this brief summary of the history of these discoveries, we observe that in all of them, there are a Nobel Prize related to these discoveries. With my knowledge, Pierre Curie, he discovered the piezoelectric effect in 1880. He never received a Nobel Prize for this discovery. But if you ask to the general practitioners about the best discovery that impacts more in his clinical practice, they say the ultrasound, not the stethoscope. They say ultrasound. But ultrasound is based in the knowledge about biology, naval applications, military applications, and industrial applications. At the end, now we have a very powerful machines that allows us to obtain images with ultrasound from our body. All of these devices consists of a generator, transducers, processing unit, and a monitor. In the transducer, you know that the most important question is the piezoelectric effect. When a crystal receives an electrical impulse, it provokes mechanical movement internally in his structure, and he makes a mechanical sound. When this crystal receives a sound, it provokes a change in this structure, and it makes an electrical impulse. In the tissues, the impedance is the resistance that the tissues offer to the passage of ultrasound. When there is a change of impedance, it provokes an echo, and this echo is studied by our machines to create our images. There are a lot of transducers, and there are different types of ultrasound transducer depending on their applications. The most used in my clinical practice is the convex and the linear. The convex for deep structures, and they use less frequency, and for the most superficial structures, we use a linear transducer with high frequency. These are different examples of these different kind of transducers, the convex one and the linear one, and these other are endocavitary. There are different ways to represent the information obtained from the echoes received by the transducer. The most common are the A mode related to the amplitude, is the first application of ultrasound in medicine. The M mode related to the movement is mainly used in echocardiography. And the B mode related to brightness is the most used in medicine in real time, two-dimensional, and with grayscale. Here in this slide, you can see this B mode scan of the liver with vessels inside, and here this echogenic line is the diaphragm and the lung with this artifact. We can improve the B mode, moving the gain, the frequency, the dynamic range, the grain maps, the level of focus, the number of focuses, the frame rate, the harmonics, and we can establish the different categories in the tissues depending the echogenicity. The anechoic tissues like water or vessels, the hypoechoic, the isoechoic, and the hyperechoic. The echogenicity is a relative question because you can see here the same lesion with the same gray scale in this lesion, but here is hypoechoic and here is hyperechoic depending the surrounding tissue. As you know, the Doppler effect allows us to study the direction and the speed of the red blood cells into the vessels. When the red blood cells are approaching to the transducer, this echo returns with more frequency. And in the other hand, when the red blood cells are going away the transducer, this echo returns with a low frequency. This difference between emitted and received frequency is related with direction and velocity of these red blood cells. Unfortunately, this depends on the angle of incidence. In this equation, we have a constant, is the ultrasound speed as an average in our body. The angle is better if it is less than 60 degrees. As you know, the velocity of ultrasound and sound, it depends of the material where they transmit. And in our body, there are a lot of different tissues with different velocities. But as average, we have this constant because our machines need this constant, this value to solve these equations in real time. Doppler may be continuous or pulsed, and pulsed may be expressed like a spectral record, color Doppler, or power Doppler. The red indicates approaching, the blue indicates distance, yellow indicates high velocity, and green indicates high negative velocity. Power Doppler is not affected by the angle of incidence, and with power Doppler we don't have aliasing. In this slide you can see examples of different spectral Doppler patterns in the suprahepatic vein, the portal vein more continuous, and in this hepatic artery with this systolic peak and this plateau diastolic. This is an example to observe the differences between the color Doppler affected by this perpendicular incidence of the ultrasound beam, that not affects the power Doppler. We can use the gain to modify the amplitude of this echo received, and we can improve the image moving the gain. Or we can improve the visualization of deep vessels going down with the frequency of the Doppler. Here, this portal vein is best seen because we decrease the Doppler frequency. Another interesting question is the pulse repetition frequency. It's like a bats. When they are near or very close to this prey, they increase his pulse repetition frequency. In the same way, when we want to depict better the high velocities into our vessels, we increase the PRF. With this, we enlarge the range of velocities, the positive velocities and negative velocities. But when we have a low PRF, it maybe appear aliasing or when the extremes are touching, because when the velocity is in the vessel is higher than this range, we change the color in the other opposite side. We can do an electrical steering when vessels are perpendicular, and we improve the signal Doppler. I want to talk about contrast enhanced ultrasound. Ultrasound started in 50s, and the saline solutions was a useful tool to cardiac studies. But these bubbles created with these saline solutions were so big, and they didn't cross the pulmonary barrier. When computed tomography appears, immediately iodine contrast appears too, and the same with MRI. When MRI appears, gadolinium appears too, to enhance this kind of studies. But we change the millennium, and when we start this new millennium, we had contrast for ultrasound. The question is that the secret is that we need very small bubbles to cross the lung barrier. And the first aim with these bubbles was to improve the Doppler, and as an echo power, the signal provided by the Doppler. But unfortunately, it was not a good results, and we decided to obtain information about directly about these bubbles with this gas, this inert gas inside, sulfuric hexafluoride. They observed that these microbubbles had an harmonic response, and in contact with ultrasound beam, they go in resonance. If we decrease the mechanical index, we have non-linear behavior. But if we use this usual mechanical index, we destroy bubbles. And the information related to the contrast enhancement ultrasound is provided by the second harmonic. we filter the fundamental frequency, and we have the information provided by these microbubbles directly in our images. We prepare the contrast, mixing this saline and this gas with this lyophilized material with phospholipids and palmitic acid, and we obtain this syringe with a lot of millions of microbubbles. When these microbubbles are distributed for our body, we can see how, for example, in this case, we can see this lesion with a big uptake of contrast in this arterial phase. Now we are using a low mechanical index for not destroy these bubbles. On this half of this screen, we have the fundamental frequency, but here we only have the second harmonic. An example of this lesion near the gallbladder that has this uptake of contrast in this arterial phase in a radial way, and perhaps is a focal nodular hyperplasia, a benign nodule in the liver. With ultrasound, we can study the hardness and stiffness of tissues. To do this kind of studies, elastography, we do an emission of a high intensity sound wave that shakes the target tissue. Immediately afterwards, this movement and this ripple of the tissues generated by this initial wave are studied with lower intensity ultrasound. If this movement is quickly extinguished, the tissue is hard. And in contrary, if this movement lasts over time, tissue is soft. With elastography, we can evaluate the degree of cirrhosis or to suspect the malignancy of a tumor. Like in this breast cancer, you can see with elastography this red signal indicating hardness of this lesion, like a breast carcinoma. Radiologists have information in these 2 dimensions with this bidimensional plan, and moving this plan through our structures, we can understand the 3D dimension. In this example, we have this shape, and we can obtain a lot of shapes depending the position of this this plane of section, and we obtain this this volumetric information. With ultrasound, we can add a plan of each section like a span, or with a linear displacement of the transducer, and in this way we can obtain 3D information, or we can obtain 3D information with a big transducer directly in a single way, or with a 4th dimension, and this 4th dimension is the time. Here is this fetus, and I think that he is a little bored about my conference. What can we do when a lesion is not clearly seen with B-mode ultrasound? We can use a geolocation systems to track the position of the transducer with respect to the patient's body. We can synchronize the ultrasound study with the reconstructions in real time of the CT or MRI of the patient where the lesion is visible. Here you can see the generator of this electromagnetic field, the transducer and the tracker that are assembled together, because with this tracker we can know with 6 degrees of freedom the position, exactly the position of this transducer. Here you can see a CT scan of a liver of a patient with a liver cirrhosis with a small hepatocarcinomas. These lesions with this uptake of contrast in this arterial phase are related with small hepatocarcinomas in this context of cirrhosis. But this depth lesion is not seen properly with ultrasound. This ultrasound section is reproduced with this synchronization, with this fusion, with the CT scan, and we can see these 3 small lesions. And thanks to this mark and this fusion, you can see this vessel, this portal vessel that coincides with this vessel with a CT scan. And we can put the needle into the liver, and we introduce the needle, and we put the needle into the lesion, and then we can treat with radiofrequency. We activate this needle with the generator, we create heat, this echogenic cloud is vapor, and we treat by heating this tumor. At the end, we put contrast and we observe this absence of uptake of contrast in this ablated or necrotic area. We can do with thanks to ultrasound interventional procedures guided by ultrasound. Ultrasound is a very good technique to guide our interventional procedures. We can do punctures, biopsies, drainages, ablations. With real time, we can control the tip of the needle. We obtain some fluids to evaluate. We have different type of needles, different type of needles of biopsy. And with ultrasound, we can guide these procedures and we obtain these samples. Or in a patient with a fluid collection into the liver, we can put the needle with a Teflon catheter around the needle, and then we take out the needle, and it rests here the pigtail, this catheter with the shape of pigtail inside, and we obtain this fluid. Or to guide radiofrequency ablations too. This is an example of a lesion, an hepatocarcinoma between the suprahepatic vein, the portal vein, and vena cava, inferior vena cava. Is the lesion, the vessels with Doppler, the lesion with contrast, this uptake of contrast in arterial phase, and then after this washout, typically seen in hepatocarcinomas, and we introduce the needle, avoiding touching the vessels, like a player rugby putting the ball between the posters. And then we activate this needle of radiofrequency and we treat by hitting this lesion. At the end, we retire the needle. This is this cloud, this echogenic volume is the cloud of vapor, and the lesion is treated. The vessel remains with permeability, and with the CT and the MRI, we can prove that this lesion is completely treated with radiofrequency. Another case of a young woman with breast hepatic metastasis is not a good indication, but this patient responds very well to the chemotherapy, and with the PET scan we have this activity here that corresponds to these two lesions that uptake contrast in arterial phase, and they have this washout. Then we can introduce the needle into this lesion along his long axis, and then we treat the first one and the second one. Now this patient is free of oncological illness. We can treat two renal tumors, like this tumor in this left kidney, and this is the correlation with the CT. And after radiofrequency, we can observe this treated tumor with this shadowing, because this dry tissue secondary to the radiofrequency ablation makes this shadowing, and it correlates with this shrinking of this tumor completely ablated. We can treat two benign thyroid nodules with radiofrequency. We put the needle, and when we are at the end of this lesion, we take out the needle carefully with the generator activated, and we burn a lot of different trajectories using this technique described by Professor Baek from Korea, called moving shot technique. At the end, we use contrast to prove that it's completely ablated. Like in this case, observe this big lesion, and 1 year after, this lesion has a very important shrink. In a complicated oncological situations, we need to mark some metastases. For example, in this case, with a lot of metastases in the right lobe, but the only one in the left lobe we must to mark. With ultrasound is not very well seen, but with CEUS, with contrast enhanced ultrasound, we can see very well this lesion, and we put a fiducial marker with this reverberation, and we can localize the location of this unique lesion in the left lobe and observe the absence of the right lobe. Sometimes we must to treat some lesions very close and near bowel, and in this situation we put needles into the peritoneum, and we put saline between the liver and these intestinal structures, and we can treat with radiofrequency, putting the needle into the lesion and treating this lesion safety, avoiding complications in the bowel. Radiologists have a lot of important role in the operating room, because with surgeons we do a combined treatments. We put the transducer in the surface of the liver, and here you can see this scar produced by the radiofrequency when we treat some metastases not candidates to be treated with surgery. In this lesion, you can see the needle geometrically in the center of the lesion, and all of this echogenic image corresponds to the vapor. Now, I want to explain to you oncological treatments. You know, for your better understanding, that there are three main pillars in these oncological treatments: the chemotherapy, the radiotherapy, and surgery. But now it's appearing powerfully interventional oncology. Interventional oncology consists of endovascular treatments, but these tumor ablation techniques. The tumor ablation techniques may be thermal or non-thermal, and thermal by heating or freezing. But another division of these ablation techniques are chemical, with alcohol, biochemical, biological, because now under study we are using oncolytic virus into the tumors, and all of these energy-based methods. Radiofrequency is the most important, and I want to stress the importance to this emerging importance of focused ultrasound. With radiofrequency, as you can see, you create heating, and the question is that water is not a good transmitter of electromagnetic energy. This energy is transmitted at the tip of the needle, because there is like an antenna, and it emits the radiofrequency, and this energy is contained around this tip of the needle. There is a ionic agitation. It increases the temperature, and it produces a coagulative necrosis. Microwave in the same way. Laser more or less in the same way. With cryoablation, we use freezing using this Joule-Thomson effect, that the compression of a gas makes cold, and with cold we may make these cytotoxic effects. Electroporation is a non-thermal ablation, and we create this disruption of cellular membranes. This electroporation is irreversible, but it may be reversible. And now our topic, the focused ultrasound. There are in general, two different types. HIFU, related to heating, and histotripsy, related to cavitation. Now, I want to explain you these biological effects of ultrasound. Ultrasound may produce heat or cavitation. Other biological effects are to increase the permeability of vessels and to the permeability of blood-brain barrier, or activate the immune response, or to do a neuromodulatory effect, or sonoporation, or liquid biopsy. As you know, physiotherapists and rehabilitators use ultrasound for therapeutic purposes. They increase the temperature of our tissues, creating an inflammation, a controlled inflammation that promotes healing. And as you know too, with a literature using shock waves, the stones of kidney and ureter may be crushed to make them smaller, and thus get them to be expelled through the ureters and urethra. Have you ever burned a leaf with a magnifying glass concentrating the sun's rays? I'm sure, but we can do more or less the same with ultrasound. We may do heat or cavitation in a tumor. We can burn cells, or we can destroy mechanically cells. To obtain heat, we use a continuous wave, but to do histotripsy, we use a high-intensity focused ultrasound with a very short pulses. With HIFU, we can burn cells and destroy membranes. And with histotripsy, we create these bubbles from the gas that exist in all the tissues of our body, and these bubbles destroys too mechanically these membranes. This liquefied tissue has a very important properties because it provokes and stimulates an immunological response against the tumor, and we call it this abscopal effect, an effect away from this target, from this tumor treated. In Vall d'Hebron Hospital, we had the privilege to treat as the first time in the world in humans hepatic tumors with histotripsy. This is the plan of the treatment of the lesion. This is during a treatment, you can see this echogenic focus that corresponds to this bubble cloud that destroys the tissue. And this treatment is robotically assisted and with the movements of this mechanical of this robot. This is an example of our first patient with an multifocal hepatocellular carcinoma. This small lesion with this uptake of contrast is an hepatocellular carcinoma, and the day after the treatment we can see this big hole, this area of avascular area with this destruction of this tissue, and during time there is a shrinking of this lesion. With MRI we can see the same, the lesion, the treated area, and the shrinking, but observe that other lesions in the liver remains invariable. The question is that with this biomarker, the alpha fetoprotein, we have, when we start the treatment, 2,172 of alpha-fetoprotein, and 4 weeks before, we decrease this biomarker, because in this patient, the first patient that we treat with histotripsy in Vall-d'Hebron Hospital, she had an abscopal effect. I'm finished this talk. Thank you for your attention. And I want to stress the importance of ultrasound for the diagnostic and the treatment. Thanks.
Thank you very much, Dr. Serres, for this interesting and illustrative talk for acoustian such as. It's great to see how acoustics is a powerful tool to take care of people's health, and how the technology, the new technology, improves his effectivity, the effectivity of this tool. Now we have some time for discussion and questions. And if somebody from the audience has any question for Dr. Serres, this is the moment to do it. To break the ice. Listening your presentation, I conclude that a doctor who use new generation ultrasonic devices must have a deep knowledge of the technology they are using. How easy is to teach this technology, the technological knowledge, to medicine students?
Yes, there is different levels to share this knowledge. In my university, we explain all of these contents, and our students go to our department, and this is this first medical formation. But after, there is the residence, and our residence has a lot of knowledge of this kind of devices, because we are working in a reference hospital, and we work a lot. We have a lot of patients, and they have the opportunity to have this kind of specialized knowledge.
Thank you very much. Any question from the audience?
Hello, I don't know if you listen to me. Yeah, I think you.
Hello,
Mr. Xavier. Thank you for your talk. Very interesting for us as more technical people. It's very interesting to see what you are able to do with all the devices that we study. I have a question related with the difference between the classical HIFU treatments and the new histotripsy treatments. I know HIFU has been used to treat some kind of cancers, like, for example, prostate cancer or some abdominal cancers at some point. But my feeling is that the results has not been finally clinically implemented. My feeling is that, for example, in prostate, there are a lot of experience, but it's not the final technique. There are another possibilities, like, for example, another possibilities. No, I don't know what's your feeling for histotripsy related with, for example, hepatic or pancreatic cancers, it's very different when we compare with HIFU treatments in the past?
Oh, Paco, it's a pleasure to share with you this kind of information in this situation now. But I know it that HIFU exists, but it hasn't no a lot of interest for me. But histotripsy is different. The difficulties to apply radiofrequency, because we have the limitations of bones, ribs, bowels, gas into the stomach, but is the same source of energy, but the kind of treatment is different, because histotripsy allows us to treat without heating. Heat, it's the cause of damage of near structures. But with histotripsy, we can treat with very precision some tissues, with the condition that we are a very good window to accede to this lesion. And I'm very excited with this new technology that appears a lot of years after the HIFU appeared. And because this immunological response related to this mechanical destruction of cells is very interesting, because histotripsy exposes a lot of tumoral antigens in our immunological system, and it activates this immunological system. And I've seen this effect, this abscopal effect, in 3 of 8 patients that we treat only with histotripsy. And this excited me a lot. And now, as you know, with one of these new pillars too in the oncological treatments is the immunotherapy. With the immunotherapy, we stimulate to this own immunological response against the tumor. And this coincidence between this mechanical destruction and this immunological treatments is a very confluence of knowledge that in my impression, is a very good line of research in the next future. And now, you know that it's the reason why we created our own line of research in Vall d'Hebron Hospital. It's this reason. I think that now I'm not a lot interested in HIFU to create heating, but yes, with histotripsy to destroy tumors, to expose tumoral antigens, because, for example, in pancreatic cancer, we can do this. And when we put oncological virus into the tumors, our aim is the same, to destroy cells with the virus and to create this immunological response is very interesting.
It's like you are more precise, you have less secondary effects, and also you have the immuno response. So it's something like always positive in the procedure.
To obtain this, we must make very short pulses, high intensity focused ultrasound, in difference with these continuous pulses to make heat.
Okay, thank you, Xavier.
Okay, thanks, Paco.
We still have time for more questions. Is there any question from the audience? Okay. Dr. Serres, thank you very much for being here. It has been a privilege for us to have you here. Thank you also for all the attendance to this talk, and see you in the afternoon sessions. See you. Thank you very much.
You are welcome. Thanks.